Good evening, everyone, and welcome to this evening's webinar, which is What's New in Metastatic Bone Disease. And I'm pleased to welcome Mr. Gerrand from the Royal National Orthopaedic Hospital in the UK. So the format of the meeting will be that we will have the lecture and then we'll probably do the quiz straight after the lecture, and then we'll do invited questions. So if you do have a question, then if you can type it in the chat, we'll keep an eye on the chat and we'll ask Mr. Gerrand at the end after the quiz. Following that, we'll stop recording and we have space for 3 candidates to do a practice viva of 5 minutes each and then get feedback from the faculty that are attending this evening. We'll stop. With me this evening, I have Hannah and Lydia from OR UK, as well as Ashraf and Mohammed, who are part of the Orthopaedic Academy faculty, and of course Mr. Craig Gerrand, who is our guest this evening. So as always, the video will be available on YouTube shortly, as in a couple of days after today. So if you miss any part of it, you don't need to panic, you can go back and watch it again. For those of you who want certificates, if you contact OR UK, fill in your feedback forms and they'll provide you with CPD certificates. So I think without any further ado, I will introduce Mr. Gerrand, who has very kindly come to talk to us about really, I find it very interesting, metastatic bone disease. So I hope you all will too. Thank you, Mr. Gerrand. Over to you.
Thank you very much, and it's a joy and a delight to be here. Thanks very much for asking me to come and talk. I'm going to talk to you a bit about what's new in metastatic bone disease, and as you heard, happy to have a conversation about things afterwards. So I work at the Royal National Orthopaedic Hospital, which you might have heard of in Stanmore, and I've been there since 2018, having worked for many years before that in Newcastle. It's not as falling down as it used to be. There are some new bits, although there's still a long corridor with an entertaining slope, and there's still some bits in need of a bit of refurbishment. But you're welcome to come and visit. Just let me know if any of this is of interest to you. So we're going to talk about a bit about metastatic bone disease. So these are the kind of things that you always wonder about if you're a trainee. These are the kind of questions you might have, or if you're not a specialist in orthopaedic oncology. So one of the questions is, what's the diagnosis? And of course, that's an absolute classic for the exam. Don't fall into the trap of nailing a solitary metastasis. You've got to ask yourself, what's the diagnosis for this lytic lesion? And then, of course, should this patient have an operation? If they should have an operation, what operation should they have? And then who should do it? So we'll touch on some of these issues, but these are the kind of questions that people ask. So bone metastases are often a presenting feature of cancer. They present in a number of ways. They cause pain, hypercalcemia, fracture, spinal cord compression, and pancytopenia. So these are patients who are generally not well. And they're quite different to other orthopedic patients, you could argue, who very often would have a single system disease. They get pain from mechanical instability, increased interosseous pressure, and probably nerve involvement. But it's really mechanical instability is the thing that we've seen most of. Why do bone metastases occur? Well, this is to do with delivery of cancer cells to bone from the primary tumour. You'll be familiar with Batson's vertebral venous plexus, which is a valveless venous system which allows retrograde embolism. And it's for that reason it is said that prostate cancer ends up more often in the spine than in other places. But generally speaking, it's about the seed and the soil, if you like. That was a theory from Paget at the end of the 19th century. But where you commonly see metastases would be the vertebrae, pelvis, ribs, femora, and the skull. When tumour cells enter bone and they go through a metastatic cascade, to do so, they can be directly lytic. So they release metalloproteinases, which are enzymes which attach basement membranes and so on. They can stimulate osteoclasts, and as the products of bone matrix degradation, such as TGF-beta, they can stimulate tumour cell growth. So there's a positive feedback. So you see in the diagram, you've got a tumour cell, stimulates osteoblasts, osteoclast precursors that become lytic in bone, and that in turn releases TGF-beta. And so this kind of cascade can be interrupted by some drugs like bisphosphonates, and that's particularly the case for tumours that are very lytic. They may, bisphosphonates may have a particular, or denosumab, which as you know is a rank ligand antibody, is particularly useful for example, giant cell tumours of bone, which are primary bone tumours with a lot of osteoclasts in them. How big a problem is it? Well, there's 250,000 new cases of invasive cancer per annum in the UK. 40% of all people will get cancer. It causes about a quarter of all deaths, and 60% of them, or higher in fact, all have bone metastases. 5-year survival is about 80% for breast and prostate cancer, is improving. And so metastatic bone disease is something that you start to think about, not just the urgent fixation of fractures, but also the longevity of reconstruction. It's the first presentation of cancer in about a quarter of patients. And a figure from the States suggested that treatment of metastatic bone disease alone may account for 20% of the overall cost of cancer treatment. So it's a big deal. These are some figures from Scotland, where the projected number of people living in, people in Scotland dying from multi-morbidity associated with palliative care is going to go up and up. So if you look at the graph, the purple graph is a projection for 2040, where you're going to see, particularly in the very elderly population, far more people dying of multi-morbidity, which requires palliative care and for which the treatment of metastatic bone disease is a part. So you can see there's an increasing demand for it. The counter argument to that might be that there'll be other treatments like drug treatment that might mitigate that to some extent. And that, I think, has certainly been the case in my professional lifetime with some diseases like multiple myeloma and breast cancer, where patients may have other lines of treatment they can take. And actually, we do see a response to things that a few years ago we'd have said, you know, that lesion definitely needs fixation, but now we'll see some response to treatment. So patients classically present with pain, swelling, pathological fracture, loss of use, or neurological changes, sometimes as an incidental finding, and usually with an abnormal X-ray. But when you see an abnormal X-ray, it's very important that you stop. And this is there's plenty of literature from this, quite good publications, and I'll show you some of them from the group in Leiden, who've tried to codify some of what should happen when you see a patient with metastatic bone disease. The first thing you do is stop, think, and stage and act. Okay, so there's no need to take someone with a pathological fracture directly to theatre. You need to work them up to work out what it is that's going on, whether an operation is appropriate. It's one of my favourite pictures. I got a phone call when I was in theatre to say this gentleman who's had prostate cancer has broken his leg and he needs an urgent operation. Is that all right? And of course, you look at this and you say to yourself, well, look, here's a lytic lesion in bone, and you ask yourself, where is it in the bone? Well, it's central. It's in the kind of proximal metastasis, diaphysis. What is it doing to bone? Well, it's obviously making a hole in the bone. What's the bone doing in response? Not very much, actually. It's not managing to wall this off at all, although there is this kind of possibly long-standing calcification in it. Is there a matrix? Possibly, again, this long-standing calcification represents a matrix. And is there a soft tissue mass? Not really. But if you look carefully at the soft tissues, you'll see that this is actually an open fracture, and this segment has come through. And although this patient had prostate cancer, this isn't prostate cancer at all. This is a dedifferentiated chondrosarcoma in an elderly gentleman. And the last thing you want to do is nail this. This is a primary bone tumour with admittedly a poor prognosis. That's not something you're going to improve by nailing this. And so this patient had first aid to the wound, had a biopsy of this, and that's how we made the diagnosis. And then went on to have an endoprostatic replacement, which this is the right treatment. So don't forget the basics. Take a history, examine the patient, and this is where you need to be a bit more general surgical, if you like. You need to be examining somebody's abdomen, the lymph nodes. You would consider, I suppose, in some patients whether they needed a breast exam or even a rectal exam, well, that would be pretty unusual. But you certainly want to make sure that you've examined the patient properly. And think about the basic investigations. So the blood tests, the ordinary x-rays, before you get as far as doing scans. You consider doing a biopsy if you don't know what it is, and you consider staging. And it's obviously important for these complex patients to think about including their oncologist, palliative care team, and also to work out what a patient's anaesthetic options are before you commit them to quite big surgery. Biopsies are pretty straightforward to do. So here's a true cut biopsy. You can do this under local anaesthetic for a tumour that has a large soft tissue mass. This is a drill bone biopsy needle in the bottom left. And this is a picture of me doing a biopsy with a true cut needle of a bone tumour under local anaesthetic. So they can be pretty straightforward to get some tissue and decide what this abnormal lesion is. There are systems, and here's the Leiden group again. And they suggest that actually, if you have somebody with a suspected pathologic lesion, you want to do the appropriate investigations and work out whether this patient needs referral to an orthopedic oncology centre, whether they just need care and comfort, or interestingly, in Leiden you can select euthanasia, I understand, whether their life expectancy is less or greater than 6 months, whether they have a fracture. And so to do that, you basically approach this in a systematic manner. So what's the origin of the lesion you can see in bone? If you don't know where it's from and it looks like a metastasis, then you would consider doing staging for the patient. So CT of chest, abdomen, and thorax, possibly a PET CT, and then you consider a biopsy. If they have a primary tumour with an unknown bone lesion, then again, you'd ultimately want to do a biopsy. If you know the patient has metastatic bone disease, after you've done the biopsy, then you want to ask the questions in the box below. If you think they still may have a primary bone tumour, then you refer them to an orthopedic oncology centre. And so what you're trying to do here is work out how extensive this patient's disease is. So that's what the staging is about. What's their general health? Take a history and do blood tests. And what's the involved stages of the local bone? So you need whole x-rays of the whole bone. And then whether or not they're having a fracture. So you can refer to this later if you like, but it gives you a general scheme for how you might approach a patient with a lytic lesion in the bone. So, of course, each kind of bone metastasis has its own personality, if you like. So breast cancer, classically presented as mixed lytic or blastic picture. You can get response rates of 50 to 60% if they've got appropriate treatment options. And that's why it's important to know if this patient, for example, is treatment naive, if they've never had any treatment, then some of this might get better on treatment. The 5-year survival is about 50% if there's bone-only metastasis, and reconstructions need to be durable for that reason. And survival after bone metastasis breast cancer is getting better. It's better if you have ER-positive disease. Okay, that's the first line on the left-hand graph here. It's better if you have single metastasis. If you have a single bone metastasis, about 70% of people are around at 10 years. So again, you want to treat that properly and with a durable reconstruction. This is a patient, it's one of my favorite x-rays, which tells a story about a lot of things. I'm not going to bring it up in the Viva, but it's this shows a patient with prostate cancer. Why do you have prostate cancer? Well, look, you can see that this is a very sclerotic, so it's an osteoblastic metastasis in the left proximal femur. It's been collapsed to the femoral head. On the right side, the patient's got end-stage osteoarthritis, and that's just a reminder to say that patients with metastatic bone disease, their pain might be due to something more mundane than a metastasis. And they've also got a ureteric stenting. So this is a patient who's obviously had some kind of pelvic radiotherapy. So all that adds up together to a patient with metastatic prostate cancer. So 80% of patients with metastasis have bone involvement in prostate cancer, survival 12 to 20 months, often pelvic or spinal. And fractures actually in this tend to be a bit like this sometimes. So they're more like stress fractures. The bone's quite sclerotic, but not normal, and so it can collapse. You can also get little stress fractures rather than complete fractures. And if you're ever thinking about doing a femoral nail on a bone that looks like this, bear in mind it's going to be really hard to get anything down that canal. So if you're going to do it, you've got to have an image intensifier and a drill and a lot of patience probably. We think it's important to do that. Kidney cancer is classically lytic. It's not uncommon for us to see a patient presenting with something like this, and they have a CT cap and they've got a primary renal tumour. And so a very lytic lesion like this is pretty classic for renal cancer. You can consider resection of this, and this is a condition where resection of one metastasis, particularly if the metastasis occurs several years after the primary tumour, is associated with a longer survival. They don't respond very well to radiotherapy. They're highly vascular, and in fact, a soft tissue mass like this is very often pulsatile. So if you feel it, you'll notice that it's very vascular. And about a 30% 5-year survival is quoted, although that's improving, as you'll see from here. And that shows that even people with high-grade disease, this is now 10 years old, these figures, there has been an improvement in survival. And that's due to immunotherapy and a bunch of other targeted, for example, tyrosine kinase inhibitors that are making a difference. And here's a meta-analysis that shows that if you do a metastatectomy in these patients, it is associated with increased or better survival. So the hazard ratios are improved in favor of metastatectomy. Lung cancer, however, classically lytic, about 15 to 40% of patients have bone metastases. They can have a poor prognosis, but this is changing. And it's pretty common, particularly in places like Scotland, where it's 1 in 12 men, 1 in 13 women in Scotland will get lung cancer. And that's an epidemic. There are things that are making a difference. This shows that the survival has improved over recent decades. And things like immunotherapy and other targeted therapies, particularly for people who have specific mutations, is making a big difference for patients with lung cancer. Plasmacytoma myeloma. If you see a lytic lesion like this, if you see a patient presenting with this, you've got to do basic stuff, right? You've got to do a protein electrophoresis. This could be myeloma. These are classically lytic. About 30% present with a pathological fracture, so it's not unlikely that you'll see something like this. 5,000 people a year in the UK, 40% 5-year survival, also improving. Usually in bones with a rich red marrow content, such as the proximal humerus and the spine. They are cold on bone scan, generally, and again, that's a classic exam question. And for people who don't have a fracture, the response rate of this is actually pretty good. So someone who's treatment naive could get radiotherapy and bisphosphonates with a reasonable expectation that that would heal. And in fact, I have a colleague at Stanmore called Sean Malloy, who has an interest in spinal myeloma, and he's stopped operating on patients with spinal myeloma pretty much. They get braced, they get conservative treatment, and they don't have surgery. So why would you operate on somebody with metastatic bone disease? You do it to relieve pain, to restore function, maintain independence, improve quality of life, and where you can, improve survival. And we did a meta-analysis, AJ Marvia and myself, some years ago, looking at this, and there's good evidence for these things. When you're thinking about surgery, you want to think to yourself, what's causing symptoms? Is it that guy who has the osteoarthritic hip, or is it somebody with a definite metastasis? What's the risk of fracture? Is there an alternative to surgery? How long are they going to live? Are they going to survive the surgery? And these are patients who have significant comorbidities. What operation should you do? And then who should do the surgery? So should they have, if they have advanced disease, should they have a straightforward nailing, for example, in a local hospital? Or should you put a patient sort of close to end of life in an ambulance to go to the specialist centre where they're a long way from their family? It may be some patients should have that, but also some should have treatment close to home. There are things that might put you off surgery. So the overall physical and emotional state of the patient. Mental obtundation is said to be a contraindication to surgery. So somebody who's not responsible. Hemopoietic depression. So it's interesting, we see this not infrequently, patients who've had radiotherapy or on other chemotherapy, but they don't have adequate cell counts to go through surgery. Or they have such marrow replacement that their hemoglobin is low and their other counts are low, so they may not be good surgical candidates. Patients with infected wounds, so particularly if you're going to put in big metal work, they've got a DVT, they have extensive neurovascular encasement, or the survival is very short. So somebody, for example, with lung cancer who has a brain metastasis, you wouldn't be putting them through any sort of surgery. Prognosis generally is very poor. So there's patient factors, there's disease factors. So what's the prognosis of the patient? Do they have other types of disease? And there'll be some procedure-specific contraindications to surgery. We get some quite interesting and challenging patients. So here's an 80-year-old patient. I mean, these are patients that have come up in recent weeks. An 80-year-old patient who had a thing called a gastrointestinal stromal tumor, which is an unusual kind of sarcoma, arises in the small bowel usually, with a metastasis in the pelvis. And so the conversation here, this had gradually got bigger over time. The conversation here was whether resection of this oligometastasis, meaning a solitary or very small number of one of a very small number of metastases, should be resected for improved survival. GIST is a tumor that has a number of biologic treatments for it, and it does develop mutations, so you get response for a while, and then you have to go to different agents. So reducing the number of cells might be beneficial. But for this elderly gentleman, the sort of resection it would have required for this large tumor that's adjacent to the prostate was really large. So we didn't operate. Some patients, of course, may have a fracture, and that's an indication for operating. And if you think someone's got a very high risk of having a fracture, then it's best to operate before it breaks, because the procedure is more straightforward, it's done in an elective fashion, and the recovery is usually faster. So how do you know somebody's going to fracture? Well, these are classic exam question, the Merrill's rating system, which you should know for the exam, but it has its downsides. And it doesn't, for example, think think anything about how active the patient is, whether or not their lesion might respond to radiotherapy or other treatment, for example. And the other thing you have to consider is if you're going to put someone through an operation, they can't have any other treatment for quite some time. That could be as long as 6 or 8 weeks. And for some people, that might mean they miss their window for systemic treatment. The thing that's really important, most important, I think, is mechanical pain. So if somebody has pain and weight bearing, that's the thing that really makes you concerned that they might fracture. So there's a Harrington system, bigger than 2.5 for the proximal femur, something that's bigger than 2.5 centimeters. So there's a fracture, that's true cancer. It hasn't responded to radiotherapy. These are at risk. Mural system, in particular, people with functional pain, lytic lesions, and large lesions in the peritrochanteric area. Those are the highest risks. And there's another system here, again from the Netherlands, which looks at the axial cortical involvement. So if you've got more than 3 centimeters of proximal to distal cortical involvement in a long bone, and a circumferential involvement of greater than 50%, so that's this bit over here, if that's more than 50% and the total length is more than 3 centimeters, then they would say the risk of fracture is very high and the patient should be considered for an operation. But these are the other little extras that you should consider. What else can you do apart from surgery? You don't have to operate on people, particularly if tumours are radiosensitive, if they're chemosensitive, treatment naive, or the patient's not fit. Then you've got some things, other things you can do. And just because you can't operate on someone doesn't mean we can't offer them a lot of other things. And here, if you have patients like this, if you have a good palliative care team available, then that's really helpful because they'll help contextualize this kind of big surgery for a patient at the end of life. Is that really the best way for somebody to spend their time having a big operation and recovering from it if the prognosis is poor, or if there are other ways in which the quality of life might be improved? So, for example, by using good pain techniques, radiotherapy, some radioisotopes can be helpful, chemotherapy, hormonal therapy, and so on. Splintage, walking aids, and embolization are all things that should be in your toolbox for managing these patients. So in the upper limb in particular, you can put someone in a splint, put someone in a sling, they can get up and around, and think about while you're working out what it is you want to do and whether or not other treatment might work. Performance status is really important. You've got to have a performance status of 2 or above to get chemotherapy, generally speaking, which means you've got to be out of bed more than half the day. And of course, if somebody has a fracture, they're pretty much stuck in bed all day. And so they are seldom candidates for getting chemotherapy. So although this is a blunt instrument, it's fairly widely applied. And the exceptions are made for patients who are otherwise fit but in bed for a fracture. But generally speaking, our role as orthopaedic surgeons is to get people up and out of bed so that they can have further treatment. And this is another way of looking at patients by trying to classify them into their prognostic groups. So operating on someone with a prognosis who ends up in the A group needs to have a very durable reconstruction. B, perhaps not so durable. C, perhaps they could have a nailing. And D, you probably shouldn't operate on. And the factors they've said are clinical profile, which is a slightly vague thing, but they're either pretty fit or they're unfavorable or they're not fit. Gardowski is very much like the ECOG score I just showed you. So these are the top scorers on the left, poorer scorers on the right. And whether someone has visceral or brain metastases. So if you do have visceral brain metastases, you'll automatically go in the low group. And so this allows you some kind of rule of thumb as to whether or not this patient is going to live long enough to survive their cancer. And there are other things that people look at. Glasgow prognostic score, it takes albumin and CRP and combines them in a quite straightforward manner to give you a score. And this is how it correlates with survival in breast, bladder, gastroesophageal, prostate cancer, and sarcoma. So you can use a score like this to get an overall handle on how well that patient is. When it comes to surviving surgery, these are patients from our centre. This is a study authored by Rachel Bamber, who's one of the anaesthetists at Stanmore, and it shows the overall survival of patients having surgery for metastatic bone disease in our centre. So there's only about a quarter still alive at 3 years. Yeah. And so these things are high ASA, high white count, hyponatremia, resting heart rate of greater than 100, and the type of cancer are all predictive of reduced survival in this patient group. So breast cancer has a relative risk hazard ratio of 1, gynecological cancers 2, GI cancers 3, so on, lung cancer 2.5. Okay, so again, this is a way in which you would get a handle on whether or not that patient is going to be well enough to survive surgery. In terms of surviving surgery, you want to avoid early complications. So patients who have early complications are associated with high mortality at 1 year. Again, another way of just making you think that actually what's the right thing for this patient. So once you've selected your patient, what operation are you going to do? Well, classically, trauma devices, which are load sharing, are not great for use in patients with metastatic disease. I think if you have a poor prognosis and you've got diaphyseal metastases and multiple metastases, then a nailing is a reasonable operation. I think fixation of the proximal femur with a sliding hip screw leads to that sort of situation that you see in the X-ray there, and so there's a high rate of failure. So generally speaking, replacement for that sort of lesion around the end of the bone is a better deal and is more likely to be durable than using a trauma device. It's always nice to consider, particularly if you're dealing with a small number of metastases, whether you can remove the tumor. And so I've got a slight preference for metastases where possible that we might consider curetting and placing them, and that gives you a chance to achieve better local control. You can put cement where the defect is, and it means you've got better fixation. You can follow it up with radiotherapy. However, it doesn't necessarily fix the whole of the bone, which for many years has been a kind of guideline for the treatment of metastatic bone disease. When you're instrumenting the bone, beware the frail patient with lung problems. So the patient has a pleural effusion or has multiple mets, you need to be careful about those when you're instrumenting the canal, either by nailing or by putting in a cemented implant. Okay, yeah, cementation is good for defects, but be careful when you pressurize it for the same reason. The cumulative rates of complications are as high as 40%. This perioperative mortality is high. You look out for bleeding, thromboembolic disease. The risk is likely high. People should certainly have a Doppler scan before you operate on somebody with metastatic bone disease to make sure you're not starting with one. And we do detect patients that way who have unexpected thromboembolic diseases. Some of those will get filtered before they have operation. Infection is not good. Local recurrence rates can be high. Reconstructive failure can be high, up to 40% at 5 years. Again, often because of local recurrence. So why would you do a non-block resection? Better local control. Fracture healing is unreliable. It can be more durable. Less bleeding because you're going outside the tumor. It might be associated with better survival in some patients. This is a slightly unusual case where we had a solitary metastasis after several years from thyroid cancer. We've treated it by resection and a massive allograft. So that's okay if you've got a good biological environment and the patient doesn't need radiotherapy. But it's slightly unusual choice for that, but it allowed us to do a resection that's close to the proximal femur to keep the femur. So in general, although for patients with metastatic bone disease, you generally try and avoid this kind of reconstruction because you don't want to put them protected weight bearing for a long period. But in patients for whom the prognosis is quite good, this is not unreasonable. You want to be careful with the tumor. You don't want to spread it. This is cancer that's recurred in the skin after curettage or open fixation of a metastasis in the femur. So be as meticulous as you can in terms of swabs around the wound. I like using aqueous betadine in the wound where I can because it's slightly cytocidal, and make sure that you don't leave big lumps of tumor and irrigate it copiously afterwards. So what operation would you do? Well, complications from intramedullary nailing occur longer than a year, and prosthetic reconstruction tend to occur earlier. And so if you have somebody with a very poor prognosis, there's a lot of these around, these sort of charts around, then you might consider doing an intramedullary nailing because their complications are likely to be beyond a year. The life expectancy is short. So here you've got, let's take you through this. Patients with impending pathological fractures, their life expectancy less than 2 months, either don't do anything, or if you have to, intramedullary nail fixation if they're really in extremis. Up to a year, intramedullary nail fixation, all other things being equal. If you have a solitary renal metastasis, then life expectancy more than 12 months, you can do intramedullary nailing with adjuvant local treatment and so that sort of thing, where you curette it out and try and avoid local recurrence. Or you could do, if it's next to the end of the joint, you can do resection, prosthetic reconstruction. If you have a solitary metastasis, you can resect and reconstruct a diaphyseal or in lesions at the end of the joint. So you would take those out completely, essentially. So again, this gives you a sense of what kind of operations you should select for patients in what sort of situation. Because you want to try and avoid this kind of situation where you've had, again, a renal metastasis, but this is obviously not united on the left despite reconstruction now. And so we've had to do a secondary operation for, the proximal femoral replacement. This is a patient, a young patient with breast cancer who's got essentially an intermittent fracture in the femoral neck. You can just see that on the left-hand side. And this is very good for a primary cemented hip replacement with good function. Whereas this, which is a metastatic lung cancer, that bit of bone needs replaced. And very often it will come out in pieces. We use a modular implant system, usually with an 8A coated collar, although in patients with poor prognosis, that's not essential. That's cemented with a bipolar head, and that would be our kind of standard proximal femoral replacement. Some of them come with trochanteric attachment pieces, which are occasionally of some use, which help it to resist dislocation. I'm not sure it really gives you good abductive function. That's more about the soft tissue repair, I think. And this is a patient with an unusual prostatic sarcoma metastasized to the tibia with a fracture, with pain on weight bearing, and a relatively limited prognosis. And so we've curetted that, filled it with cement, put a plate on, and he's gone back to weight bearing. Could have had a proximal tibia, but that's an operation that takes a lot longer to get over. That is the right option for some patients. This patient with breast cancer that I showed an X-ray of earlier has a very arthritic knee, so this is quite a good solution for curettage alongside knee replacement, which he did very well, actually. Another one from the clinic quite recently, lung cancer, a large lesion in the back of the femur. That's best treated by distal femoral replacement. And he couldn't straighten his knee, but once we've done this, he could get up and walk. And again, it's getting on with his life. Here's a lesion which is very vascular on the MRI scan, and this shows a lesion in the kidney. This is metastatic renal cancer, and usually for this sort of thing, we would start with embolization. So we would do this to try and reduce the vascularity of it. For most metastatic renal cancers, it can be extremely vascular, and so this is embolization. So you need a interventional vascular team available. And we've taken it out, replaced it with distal femoral replacement with a rotating hinge, which again is our standard thing. Some patients have a lot of surgery, and standard arthroplasty techniques can be quite useful. I'm sorry, that's all I've got is a CT scanogram, but you see there's been collapse of the femoral head on the left. So this patient had a hip replacement with TMT augment, equalized leg lengths, did very well. And then the next thing, I'm surprised to hear, is he broke the other hip. In the meantime, it has spinal decompression. But so you had a proximal femur on the other side, and then actually, I'm going to show a slightly different patient. There's a patient with another patient, the kind of thing, people that we see. And so you do have a number of options up your sleeve, but essentially we can go large if we need to, and we can replace the whole femur. So this patient again had a kind of hip replacement reconstruction on the other side. And most bones you can replace. Here's metastatic renal cancer in the proximal humerus, and this is a Bailey Walker shoulder. So this is a constrained reverse ball and socket shoulder that helps you with one of the major problems, or the major problem, for proximal humeral reconstruction, which is instability. And there are even we can do wraparounds. This patient actually had a pseudoaneurysm because of metastasis in the distal humerus. So we've got a number of quite innovative solutions for the right patient, or you can replace the whole humerus. Most implants now come with a silver coating, and we often use this thing, which is a tumor tube. We call it a tumor tube, but it's essentially a knitted polyester sleeve that you can use to enhance your soft tissue attachment. So what does high quality care look like? Well, for many years, the BOA published Metastatic Bone Disease Guide to Good Practice, which I think you can still find, but actually, as with everything else, is now a BOAST guideline for management of metastatic bone disease. So I would suggest that you read that and know about it when it comes to the exam, and actually just for your daily trauma take, because it's got some very useful advice on it. From Scotland, again, there's some very good studies from Downey et al. Asking people using what's called a Delphic technique. So asking people what they think are the most important things for patients with metastatic bone disease. What does high quality care look like? Well, it looks like prompt orthopedic assessment It looks like rapid investigations, a surgical decision quickly, biopsy of solitary lesions, a good oncology input early. Adults with fractures should have surgery without delay. They should rehabilitate early. Patients who are dying, that needs to be recognised. They need to have a good palliative care input and ceiling of care, so everyone needs to agree what maximum is you're going to do. Every hospital should have a metastatic bone disease pathway. There should be education, and we should know by collecting outcome data what the impact of our surgery is. But we know from a recent audit, the British Orthopaedic Oncology Society audit, shows a wide variation in care and delays for patients who have metastatic bone disease. This shows that patients in a specialised centre on the left, it does take longer for them to get from fracture to surgery. So one of the disadvantages of referring to a specialist centre is that length of time. And I know from experience locally, patients spend a long time languishing in other hospitals before they get to us. And I think that's really a call to arms for everybody. The patients who have metastatic bone disease, get them investigated quickly and get them get the oncology advice that you need quickly, but try and make a decision and get them to the care they need as quickly as possible. It doesn't have to be as fast as, within 24 hours for a hip fracture, but the same arguments apply. The longer people wait, the harder it is for them to rehabilitate. So to conclude, patients with metastatic bone disease deserve timely and appropriate surgery. It's got much to offer them. You should stop, think and stage and act. Don't miss a primary appointment. Consider the whole patient and the diagnosis. And wherever you are, consider what your local services and pathways are and how you're going to meet quality standards. That's very rewarding, actually, group of patients. And that, if you're all still there, is the end of my talk. So we'll move on to the next bit, if that's all right.
That's great. Thank you so much, Mr. Gerrand. I found it really interesting. So I haven't got any questions yet, so people can have a little think about that while we launch the poll. So if you can all answer quickly, it's completely anonymous, and then we'll move through and Mr. Gerrand can discuss the answers with us.
So it's a slightly upside down question, for which apologies, but basically these are statements from the post guidelines, apart from one. And the first one says each unit should have an agreed policy for the multidisciplinary discussion and management of metastatic bone disease, including clear pathways from referral. Yes, they should. And so that's supported, so that's not the answer. All specialist centres should have agreed pathways to enable prompt opinion advice and transfers in the network. Yes, you should. So that's not it either. Prodromal pain history and links to your night pain raise suspicion of MBD and should be documented along with injuries circumstances. Again, that's in the statement, so that's not the answer. Patients should have a pathological fracture of the hip should have an operation within 24 hours. That is not in the guidelines. That is not in the post guidelines, because as we've said, what you want to do is be investigating. You want to stop and think before you act. And so that means that patient's going to need an MRI scan. They might need a biopsy. And so one of the trade-offs, as we discussed, is that it takes longer to go. That is the correct answer. So 70% of people got it wrong. And then metastatic bone disease without an obvious primary site should be discussed with a local acute oncology service. And that's also a statement. And so if you're following these guidelines, you'll involve the oncologist. So thank you for that. Okay. I guess we do the next one. This is a question about renal metastases. Okay, which is not true. Again, it's an upside down question. So complete removal of a solitary metastasis may be associated with improved survival. That's true. It's not that one. Renal metastases are usually avascular. No, they're usually really vascular. So that's the one. And the other points you should discuss with a treating oncologist. They're relatively insensitive to radiotherapy. And that patients may present with a bone metastasis and a CT CAP's required. They're all true. Okay. Okay, and the next one. I think everyone's answered that. I'll just go straight ahead with that one, shall I?
Yes,
so this is a question about lytic lesions in bone. So lytic lesions in bone, again, I'm asking you which is not true. Apologies if it's upside down, which is false. So multiple myeloma, if you've got a lytic lesion in bone in an adult, you should always exclude it with a plasma paraphylogene. Yes, you should. Leave a permeative transzone. So again, part of your vocabulary should be how you look at lytic lesions in bone. what's around the edge. Is it geographic? Is it permeative, or is it mothy? So geographic, bone has a chance to wall off. Those are ones you can draw around with a pencil. So they're more likely to be at the benign end of the spectrum. Lesions that are permeative are more likely to be malignant. Okay, so that's also true. It's not that. Bone metastasis and prostate cancer can be osteoblastic as well as osteolytic. That's true. So it's not that. Mechanical pain is associated with the risk of fracture. Yes, it is, in neural scoring and from clinical practice. And it's always possible to tell whether a lytic lesion in bones is a primary bone tumor from imaging alone. Of course it isn't. And that's why you've got to investigate them and make sure you don't miss a primary bone tumor. So the answer, that's the answer. That's the one that's not true. I hope they were suitably educational and only a bit confusing, as multiple choices tend to be.
That is great. Thank you. Thank you very much. I've got a couple of questions. So the first one is from Adita Kaja, who's written, if there's a newly diagnosed metastatic bone lesion, is there a mandate for a complete skeletal survey?
Yeah, so a skeletal survey is a particular thing, isn't it? It's a collection taken to mean a collection of plain films that we'd use in myeloma traditionally, where you where a bone scan isn't as sensitive. Yeah, so if you wanted to identify whether the patient had multiple bone lesions, traditionally have done a skeletal survey. However, that's been superseded in many places by a whole body MRI scan. So a whole body MRI will give you more detail about whether that plasmacyte you found, that lytic lesion in bone that you biopsied and is full of plasma cells, whether that is a solitary plasmacytoma, which is a precursor to melanoma generally, whether it's multiple. So if you have somebody with a solitary bone lesion, particularly if they're over 40, they should have some kind of skeletal imaging. That might be a whole body bone scan. That might be a whole body MR. And if it's myeloma and you don't have whole body MR, then you might do a skeletal survey, which is a bunch of X-rays. So yes, that's part of the workup. And generally speaking, if you're under 40 and you've got a lytic lesion in bone, you send them along the sarcoma pathway, because it's more likely to be that. If they're over 40, then you really must work people up locally as metastatic bone disease. So that means taking ownership, finding out if they've got a recent diagnosis of cancer, if they've got an oncologist, asking their oncologist if they have a new lytic lesion, whether that might be metastasis. And so that's so important. There you go. I hope that answers the question.
Thank you. Adita's also put a follow-up in saying, does SPECT play any role?
Does SPECT play any role? It's not something we'd use routinely as part of that, but there are, I suppose there's a way of whole body imaging, possibly, but it's not something. It wouldn't be top of the pick.
Great, thank you. We've got Saeed.
I am nailing. I see that.
Yeah. Saeed asked two questions. He's put
I am nailing from messages.
Yeah.
How important is to vent the canal? Well, the answer to that is I'm not sure of the evidence for venting it, but it's not a bad idea, particularly if you've got very frail patients with pre-existing chest disease. And certainly you'd want to make sure when you're reaming the canal, if you can, that you aspirate it thoroughly and that you're not turning the femur into a massive syringe, essentially. That's also the case if you're putting in a long stem cemented implant. So I think the answer to that is, I mean, to be honest, I don't do very much nailing for metastatic bone disease where I work at the moment, but previously I would pretty often drill a hole in the bottom of the femur and put a sucker into it, because I know the patient's at risk and I know I've done everything I can. But what I have learned is the patients who have pre-existing chest problems, you've got to be super careful with. Irrigation of the surgical site with hypertonic fluid is a fact. Yes, we do, if that's what you mean. Whether there's any evidence for it, I don't know. The things that definitely, we do it because it's fairly harmless. There are other things that are definitely cytocidal, and so things like chlorhexidine, aqueous chlorhexidine, that is available, is very cytocidal. And a few years ago, there were people who'd accidentally used it to do arthroscopies, And there's no doubt that it completely destroys the inside of a joint and completely destroys articular cartilage. And similarly, a very sort of basic compound that destroys cells, as is aqueous betadine, which is available in the theatres I work in. So if I'm particularly concerned that there might be tumour leakage, I'll pack betadine soak swabs around the wound. I can't prove to you that it makes it, but it's one of those things that makes you feel better about it. Okay, what have we got further down? Is there any role of bone cement in the treatment of bone cancer? Yes, there certainly is mechanically, right? So if you're adding bone cement to your construct, there are papers that say that in metastatic bone disease, you get longer, more durable reconstructions. And of course, bone cement is used by some interventional radiologists and some spinal surgeons doing vertebroplasty or injection of holes in bone as part of a sort of palliative procedure. So there is that role. The other question I suppose you're alluding to is whether or not the bone cement actually kills the cancer. It probably does a bit. It does heat up, and it may around the edges reach a temperature that it will kill rogue tumor cells, but that's no substitute for a proper curettage. There were some years ago cements that had chemotherapy agents in them. They didn't really catch on, I think, because people didn't really want to be handling cement full of methotrexate in the middle of theatre. So that hasn't really caught on. There are other methods for delivering chemotherapy agents now that are done particularly by interventional radiologists who can deliver the chemotherapy agents to, for example, liver metastases, but that sort of thing hasn't really caught on. Okay, Salim Bob Manuel says, how do you avoid the pitfall of missing a primary bone tumour in a known patient with a metastatic cancer? So the rule of thumb, I would say, is if they have a solitary metastasis, then that's the one that you need to investigate with a biopsy. If they have multiple metastases, then it's much less of an issue, even if it turned out to be a sarcoma, because you're not really in a situation where you're going to, unfortunately, affect a cure. So it's really the solitary bone metastasis that you are obliged to know what it is before you do something like nailing it. And so those are the places. So beware the solitary metastasis, and that's a classic exam pitfall.
That's great. Thank you very much.
The last one, isn't it? Yeah.
So I think if that's all the questions, what we'll do is we will stop recording and we will move on to the Viva sessions, and we'll